Welcome to the cure for insomniacs, supranuclear deficits. It's a very tough topic, very boring topic. Yeah, come on. Come on, Aaron. All right, so we're talking about supranuclear disease, which is a very complicated area and issue for ophthalmologists. It's tough to think about, tough to figure out, but it is on your quiz, which is in about one more year at this point, right?
Yep.
And a lot of what we do today is sort of a repeat in terms of the basic anatomy of what we did for nystagmus. But if we hear it enough times, maybe we remember some of it. So infranuclear areas, the areas that control eye movements, begin with the third, fourth, and sixth nerve. So those are the nuclei. And from them, you get a supply of all the extraocular muscles. We have the intramedullary, which is in the medulla and pons and midbrain segments of these nerves, which have central myelin. And then we have the peripheral segments of these nerves in the subarachnoid space, and then cavernous sinus and orbit. And then we have the neuromuscular junction, the junction between these nerves and the extraocular muscles, and finally the extraocular muscles themselves. So that's the nuclei and infranuclear area. But we have control further up in terms of a hierarchy of control with gaze centers that control the eyes moving together, conjugate eye movements. So for the horizontal eye movements, that's the sixth nerve nucleus, which has fibers that go to the sixth nerve itself, and the fibers that cross through the MLF to go to the contralateral third nerve. And for the vertical eye movements up and down, we have a gaze center that's the rostral interstitial nucleus of the medial longitudinal fasciculus, the interstitial nucleus of Cajal, and posterior commissure up in the midbrain area. So these supranuclear systems that we're going to talk about input into these gaze centers to make eye movements. So what are these supranuclear areas? They're all over the place. There's frontal and parietal, there's cerebellum, there's the basal ganglia, superior colliculi, which is a crucial center in the midbrain, the thalamus, a couple of subnuclei there, the paramedian pontine reticular formation, which is right near the sixth nerve nucleus for horizontal eye movements, the neural integrator, which we'll talk about, and the vestibular nuclei, which are in the pons and medulla. So again, we talked about this last time. Why do we have eye movements? In order to maintain images steady on the retina in order to preserve visual acuity. That's the basic answer. Our visual acuity in the center is 20/20, 20/15. Our visual acuity off 10 degrees, maybe 2400 or less. So in order to look at things with clarity, we need to keep our fovea located where we want to look, and we need eye movements to adjust for everything in the environment that would tend to move the eyes off. So even tiny movements of images on the retina, 2 to 3 degrees per second, will degrade visual acuity. So we have to have a very precise control of where our eyes are. And therefore, simple activities such as walking, which would make our eyes go up and down, would cause blurring if not for stabilizing eye movement, particularly in that situation, the vestibulo-ocular reflex. So what eye movement systems do we have? We have those that maintain steady gaze on an object that's not moving. And that includes fixation, the vestibular reflex, the optokinetic, and the neural integrator. And then we have systems to acquire and keep moving images on the fovea, which include smooth pursuit, vergence eye movements, that's convergence and divergence, and rapid eye movements, saccades. So let's first talk about visual fixation. Let's say we want to look at something important. Where does that begin? That begins in the occipital lobe, and it allows images to remain stationary on the fovea when the head's not moving and the object's not moving. And so that's back here in the occipital lobe down to the brainstem. The vestibular system allows images to remain steady on the fovea with brief head rotations or translations, which means moving forward. And it's mediated by the vestibulo-ocular reflex, which begins in the semicircular canals, goes into the vestibular nuclei through the eighth nerve, and eventually connects with the ocular motor nuclei. Now, the otolith ocular reflex, also called the utricular system, responds to linear head acceleration, that's moving forward, and lateral head tilts, right? And so if we move our head and we want to keep fixated on an object, the eyes maintain where they were, and that's the vestibulo-ocular reflex, right? This is courtesy of Dr. Z from Baltimore. The optokinetic system will take over when the vestibular system is saturated. So if we have sustained head rotation, the inner ear can't keep up with the stimulus, it gets saturated, and we have what's called the optokinetic stimulus, which is looking at objects, and when we test it, we use stripes like this or this, but it takes over for the diminishing labyrinthine signal and gives us a slow eye movement. What we'll see here is that we have no media. Uh-oh. We might have to get Bill back. Nothing much to see there. Let's hope these are working. They are not. Okay. But I could describe these. If we get to more important things later, we could switch to another computer. Neural integrator maintains eccentric position. So if we want to look off to the side, we need to maintain our eye to the side by overcoming viscoelastic forces of the orbit, which tend to bring the eye back to the center. The horizontal neural integrator is the medial vestibular nucleus and the nucleus prepositus hypoglossi, which is in the lower brainstem. The vertical neural integrator, if we want to keep our eyes up or down, is the interstitial nucleus of Cajal. What about if a target's moving? We have smooth pursuit, if we want to look at something, let's say left and right. And we have vergence, if it comes in closer, we want to converge, let's say. Smooth pursuit follows a moving target at 40 degrees per second. There's ipsilateral control, and it's mediated at the temporal parietal occipital junction with some input from the frontal and supplementary eye fields in the frontal lobe. Convergence and divergence keep images focused as the object moves closer or farther away, and it moves the eyes in a disconjugate way because they have to move opposite directions to do that. That also begins in the occipital lobe and goes to the midbrain or pons. The saccadic system, or rapid eye movements, allows eyes to rapidly focus on eccentric objects of interest. So if we want to look to the side, we make rapid eye movements or saccades. And it also resets the eyes during rotation, producing physiologic nystagmus, so that if we're rotating, we get nystagmus. Or if you're sitting on a train, you'll see nystagmus. It also resets the eyes during pathologic nystagmus. So remember, when we have nystagmus, the problem is the slow eye movement, and the rapid correction is the jerk that we see. What about control of saccades? Frontal eye fields, supplementary eye fields, dorsolateral prefrontal cortex, parietal eye fields, superior colliculus, the PPRF in the pons, and the omnipause neurons in the brainstem. The omnipause neurons are what suppresses unwanted saccades. What if we want to really shake it up and move our eyes and heads together, right? Then we use all these systems at once. We'll use the vestibulo-ocular reflex, the saccades, smooth pursuit, the vergence, all aimed to keep the fovea focused on where we want to do. And let's say we have a problem. We have a deficit. We have a vestibular problem from an inner ear problem. In order to overcome these deficits, we have the vestibulocerebellum, the flocculus, paraflocculus, and nodulus, which modulate pursuit, vestibulo-ocular reflex, and gaze holding, and we have the dorsal vermis and fastigial nucleus of the cerebellum for saccade and pursuit accuracy. So to review where these systems are in the brain, visual fixation is temporal parietal occipital junction. Vestibular begins in the inner ear via the vestibular nuclei into the MLF and the ascending tract of Deiters up to the oculomotor nuclei. Optokinetic is, again, probably mostly parietal, posterior hemisphere, very close to where smooth pursuit is. The neural integrator is the nucleus prepositus hypoglossi and medial vestibular nucleus, as well as the interstitial nucleus of Cajal. Smooth pursuit is the temporal parietal occipital junction. Vergence is parietal occipital and frontal, and saccades are many sites, the frontal eye fields, superior colliculus, PPRF, and RIMLF. Okay, so how do we demonstrate that something is supernuclear? We overcome the motility defect by using a different supernuclear system. So let's say we have a problem moving our eyes in one way. We try to stimulate it in a different way to overcome it. So we might use the vestibular system, and we might use Bell's phenomenon. Let's say we have a vertical gaze deficit to demonstrate that it's not in the third nerve or in the extraocular muscles themselves. So if this doesn't work, we ought to call Bell. Yeah, we ought to call Bell and hook it up. Anyone know where he is? Hopefully it'll work on here like it normally does. We'll get back to this. Bell's phenomenon, I think someone went already, by the way. So Bell's phenomenon is when we try to have someone close their eyes and we keep their eyelids open. We force it open. And what you see is a normal elevation of the eyes when you try to close your eyes. So if someone couldn't look up, and we had someone in clinic just the other day like this, but you have them try to close their eyes and you forcibly keep it open and you see their eyes go up, then you know that they can overcome it.
He's in the OR.
He's in the OR. Okay. No one else back there? Okay. All right. Well, we could try hooking up this other one anyway. Any of you guys know how to do it? Oh, we need a Mac adapter.
Fred, go.
But I don't have the adapter though.
I sent him an email.
Okay. All right. Okay. Thanks. All right. We'll come back for videos if we need to. So, supranuclear disorders come in a couple of varieties. First of all, there's imbalance, which will give us nystagmus if it's in the slow eye movement system, or saccadic oscillations if it's in the rapid. You know what we could do? We could hook in my... Yeah, Brent, you want to try hooking this up in their computer?
If you have an adapter, you can do it.
No, I could just put this... It'll probably work off my thumb drive. Yeah, because he just put it on the desktop, and I think it didn't transfer everything. You just plug that into the...
Does it work on your computer?
It should, but I don't have my Mac adapter. But we could put from the thumb drive onto the computer here. That should probably work. Yeah, that's what we should do. Yeah, no, you put it. Yeah, is that on the thumb drive?
If it's in
Yeah, see if one of those movies works. Worked last night. Worked off this one. You sure you're on the thumb drive?
my boss, blah, 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 now I'm fired. Correct.
All right.
Because it wasn't allowed to respond. Take that as
Yeah, that'll work.
All
All right. Let's try to get a Mac adapter. We can keep going in the meantime anyway. So, if there's an abnormality in the rapid eye movement system, we get saccadic oscillations. And these are unwanted saccades that are not suppressed. And they're all rapid eye movements. There's nothing slow about them. So we should talk about some diseases that affect supranuclear deficits. First of all, you can be born with a problem with making saccades, and that's called congenital ocular motor apraxia. The most important degenerative disease that gives you supranuclear deficit is PSP, or progressive supranuclear palsy. It could be acquired, a supranuclear deficit, due to a stroke, tumor, or demyelination. It can have the dorsal midbrain syndrome, which you know has trouble with upgaze and pupil abnormalities, what we'll talk about. A gaze deviation or paresis. Skew deviation where one eye is higher than the other. INO, which is infranuclear to one muscle and supranuclear to the other, and that's why it's internuclear. Peripheral vestibular disorders are supranuclear, and saccade and pursuit deficits. Congenital oculomotor apraxia is a congenital defect that involves not being able to make any voluntary saccades. So if the head is straight, you can't look to the side with rapid eye movements. And so what patients do is they learn to overcome their deficit by really shifting their head over and then getting a vestibulo-ocular reflex to come back. And I bet this won't work. It's true. And I'll bet this one won't work. You know, it worked at midnight.
You can't demonstrate the eye movements?
I can. But that's an upgrade. Yeah. Actually, so what they do is they're trying to look at, let's say I want to look over there to there. Instead of being able to make a saccade, what I've got to do is overshoot like that. And then the vestibulo-ocular reflex comes back and then fixate. And so these kids go like that. What?
I blinked. Can you do it one more time?
That's a pretty good iPhone. Did you catch the vestibulo-ocular reflex?
Not quite. Not from this distance.
Yeah. Well, when we get these movies playing, you'll see this. So the first one is a baby, and the second one is a kid who's about probably 10 years old. This is courtesy of Dr. Z, who's sitting here in the next room in the background. And no adapters?
No one knows where they are.
Nobody knows. We're a very high-tech place.
Bill, it all depends on Bill. He might be coming up.
Okay. So this kid is trying to read, and you'll see, when you read, you make saccades. And if you can't make saccades, you just got to keep moving your head. And if we get this running, we'll see it afterwards. Progressive supranuclear palsy is the most important disease to know about, which gives you supranuclear deficits. It's mostly people over 50 with a mean age of 65, slightly more common in men than women, and rarely familial. And it presents with blurred vision, trouble focusing, difficulty reading, eating, or looking or going downstairs, double vision and photophobia and eye pain. And the reason they have trouble reading, eating, and going downstairs is because the deficit begins with down gaze. And they also have a tonic neck problem where they have their neck up like this. So they can't look down and their neck's back. And so they miss things on the plate, they can't read, and they fall down the stairs, unfortunately. So the defect is more vertical than horizontal. It's more down than up. It's more saccades than pursuit. There's impaired convergence. And the VOR, the vestibulo-ocular reflex, is preserved until very late. They also have a lot of square wave jerks, these saccades that they can't suppress. So, does it even pay to try here? So, what you'll see first is that they'll be able to look up and down with pursuit, but they can't make the rapid saccades. Then the pursuit goes, eventually the vestibulo-ocular reflex goes too. Now, PSP has a classic finding on an MRI sometimes. So here's a normal sagittal view of the brainstem. Here's the pons, and here's the midbrain. So let's say you have olivopontocerebellar atrophy, a spinal cerebellar degeneration. You really lose a lot of your pons, and that's this picture here. So you see the midbrain is still normal like that. The pons is lost. And there are a lot of eye movement problems, as well as retinal and optic nerve problems in some of the spinal cerebellar degenerations. But this is what you might see on an MRI. But with PSP, you lose your midbrain. The pons is relatively normal. The midbrain is very thin. And this has been called the hummingbird sign because it sort of looks like a hummingbird if you look at it in that view. It's the best way to look for PSP on an MRI. So most of the time we'll get MRIs on these patients and the report will say atrophy, non-specific. But if you look and you'll see that the midbrain is very thin. Looks like a hummingbird. Now, PSP has a very large differential diagnosis. Multiple infarcts will do it, Whipple's disease, frontotemporal lobar degeneration, Creutzfeldt-Jakob disease, a dorsal midbrain syndrome, which is due to a mass lesion, multiple system atrophy, which is a neurodegenerative disease, familial Lewy body disease, idiopathic striopallidodentate calcification, and Lytico-Bodig disease. And I'm pretty disappointed I haven't heard from any of you in the ER with that diagnosis yet.
It's always amazing.
Tonight, I expect. Bob's on call tonight. So, PSP is a terrible disease, by the way. Death occurs in about 5 years. And eventually there's some dementia with it as well. So Whipple's disease is an infection with Trophorema whippleyi, which presents with weight loss, diarrhea, there's a joint involvement, lymphadenopathy, and fever. But they also can be isolated to the nervous system with a predilection for the basal ganglia. And the classic finding in Whipple's disease is called OMM, or oculomasticatory myarrhythmia. So these people get a rhythmic 1 per second convergence and divergence nystagmus. So it goes in and out, 1 per second, like that. It's very subtle usually, so you don't see those big excursions. It's just a little bit. And when you see that, that's pathognomonic for Whipple's disease. There's nothing else on your OCAPs that's going to have that answer. I mean, it's the only thing that causes that. But it's always seen with a supranuclear gaze paresis. So they don't just have this convergence, divergence. They can't look up, down, or sideways unless you do the vestibulo-ocular reflex. So this next patient is a 65-year-old man, sudden unresponsiveness, has a history of uncontrolled hypertension. He's got a hemorrhage in his thalamus, compressing the midbrain, giving him hydrocephalus. 5 days later, he's awake, alert, but he has an upgaze paresis. His pupils are unreactive to light. They're 5 millimeters, and he has convergence retraction nystagmus, which means when you have him attempt to look up, instead of being able to look up, his eyes converge and retract in the orbit. And this is, of course, the dorsal midbrain syndrome, which gives you light near dissociated pupils, mid-size, upgaze and downgaze paresis often, more often upgaze. The eyelids are retracted, so that's called Collier's sign. This is one of 2 places where we really see this, the other one being Graves' disease. The distinctive feature is that this upgaze paresis is supranuclear, and there's no proptosis, chemosis, etc. There's accommodation and convergence disturbances too. So they may be overactively accommodating and converging or under. So to show that it's supranuclear, you do Dahl's maneuver. So you have them look up, and they can't look up. But you keep them at that level, and then you move their head down and say, keep looking at the target. And you see that their eyes move up more. So here's a patient with a dorsal midbrain syndrome from a hemorrhage and has convergence retraction nystagmus as well. The dorsal midbrain syndrome is seen with tumors in the midbrain or pineal region, stroke, MS, hydrocephalus, with aqueductal stenosis, for instance, and also shunt malfunction. So anything that can put pressure on the upper midbrain, and if it's hydrocephalus, it's because of the third ventricle getting enlarged and pressing on that area that gives you the dorsal midbrain syndrome. And we see patients who've had hydrocephalus as a child who present now with trouble with diplopia. They have trouble looking up, looking down, and we diagnose dorsal midbrain syndrome. And we know the shunt's not working. And we call it neurosurgery, and they test the shunt, and they say the shunt's working. So we have this discussion. And we're always right because the clinical picture doesn't lie. I mean, when the shunt doesn't work, there's pressure on the midbrain, and they get trouble with their eye movements. And eventually they realize that it's right, and they fix the shunt, and they get better. Horizontal gaze paresis can be supranuclear if it's in the pons, and It ain't going to work. We know that. Oh, wait. One of them's working. So this person can't generate rightward saccades. They can't look with rapid eye movements to the right. Looks to the left, trying to look to the right, nothing's happening. Okay? What if we do Dahl's maneuver? You overcome it. It's normal. Which tells you that the sixth nerve nucleus and everything beyond it is working fine. So what's the problem? The problem is that there's a lesion in the paramedian pontine reticular formation on the right, which doesn't allow him to make saccades, but the vestibular input into the sixth nerve nucleus is fine. So he could get over to that side with a vestibulo-ocular reflex. Again, this is courtesy of Dr. Z in Baltimore. So here's a 73-year-old man, sudden onset horizontal diplopia, hypertension, hyperlipidemia is the history, and on exam has a isolated left adduction deficit with right abducting nystagmus. Diagnosis? INO, of course. So an INO is a lesion in the MLF, which connects the sixth nerve nucleus on one side with the medial rectus subnucleus of the third nerve on the other side. It gives you an ipsilateral adduction deficit because it crosses right away in the pons, so all the lesions are ipsilateral. It gives you contralateral abducting nystagmus, and convergence can be involved or spared. If it's down in the pons area, convergence is spared. If it's up in the midbrain, close to the third nerve nucleus, convergence is impaired. You may have a skew deviation where one eye is higher than the other, with the hypertropia, the higher eye, being on the same side as the adduction deficit. In young people, it's due to demyelination, almost all the time. So we had a patient I think we saw in clinic 2 days ago or yesterday who has, hey, welcome back. So my movies are not playing.
Oh.
So I could probably play them off my Mac if there's a Mac adapter. In young patients, it's often bilateral. In older patients, there's brainstem ischemia as the most likely, and that's most often unilateral. And that's because the vascular supply respects the midline. It doesn't usually cross. Whereas demyelinating lesions in the MLF are right near the midline, and they can cross over. So here's the lesion right in the pons in the MLF in that case. So again, younger people, bilateral MS, and older people, it's going to be a stroke. Here's a patient, a 70-year-old woman with dizziness and diplopia with a past history of hypertension, coronary artery disease, and prior strokes. And she presents with a left facial paresis, and she can't look to the left at all, okay? She just looks to the right with one eye. Neither eye looks to the left. The right eye looks to the right. The left eye does not. What do we call this? Right. This is the 1.5 syndrome, right? If we think of eye movements total horizontally as 2, then we have each movement of each eye is a half, total of 2. Here we have loss of everything to the left, which is 1, gone. We have loss of adduction to the right. So all we have left is this 1/2. So where do we think the lesion is here? Which part of the brain and which side? I'm going to have to take the thumb drive and put it in here, actually. Any ideas? Is this right? Nobody is wrong yet. I can just pull this out, can I?
Yeah.
Which side? Which?
Left.
It's on the left side, and which part of the brain? Huh? Midbrain. Okay, so the midbrain can give you the left adduction deficit with the MLF. Can it give you the left gaze paresis? Ah, pons. The left side of the pons, right? It's the gaze center or the sixth nerve nucleus on the left, as well as the MLF on that side. So it's in the pons. Let's try this. So how do we switch to the Mac? Can we switch yet? Or see if it works. Let's see if these movies work. It worked last night on here from the thumb drive.
That's really right.
Yeah, that's working. Look, it's worked. Oh, it's not on the other. Sorry, thanks for coming. Here? Ooh.
Not sure. No, go to the ear. Go to the ear. It's blurry when you wake up in the office. Trash is everybody's great. She doesn't cooperate. You get trash and trash.
I'm online. All right, so is that up there? Okay. Let's. Why don't I have the okay file? Slides. Got all these things. Okay, here we go.
She was like, yeah, okay. She was just like rolling with it. She was like, okay, all right.
I didn't believe it for a second, and I was like, ah.
Okay, so here we have a patient with. This is a patient with Whipple's disease, who's got two features here that you can see. First of all, he can't look to the side. He can't look up.
Thanks, Bill.
Thanks, Bill. Thanks, Nika, for thanking Bill. So, can't look to the side voluntarily, but with Dahl's maneuver can look to the side fine. Can't look up voluntarily, right? So, to show that this is supranuclear. But also, if you look very carefully, he's got these convergence, divergence eye movements that are very subtle. They're just very small in terms of amplitude, and they're in and out. I don't know if you can appreciate it there. It's going in and out, 1 per second. Here's the congenital oculomotor apraxia. So this is from the Novel website, which you should all use, which has great videos on neuro-ophthalmology, and it's free. You can download it for teaching and learning purposes. And this is from Shirley Ray's collection, and is a 16-month-old with congenital oculomotor apraxia. As he looks around the room, look how he does it.
With oculomotor apraxia, turn their head instead of their eyes to try and fix an object off on the side. The head moves past the object of regard and then comes back to normal, straight ahead.
And then here's an older kid trying to read.
Before standing, if you get dizzy while standing or sitting, lie down immediately. Number 5, avoid straining during a bowel movement, as this can lower blood pressure. Treat constipation
So
with a stool.
eventually, at age 20 or so, these often get better, and the patients can start making saccades in many cases. Here's the PSP patient, again from Dr. Z.
And look down.
See that slow looking down? The saccade is slow looking down.
And look way down.
It's slow up, but it's slower down,
Far
actually.
down, as far up as you can. And now look straight. Look a finger at the camera. Center of the camera. Blinking light. Finger. Camera.
So that looking down is a lot slower than it should be for a rapid eye movement.
Camera. Down with the finger.
Dr. Mohammad,
Yeah?
what do you recommend for the kids with congenital oculomotor apraxia? Do they get some type of visual therapy until they're in their 20s, so they're literate?
I don't know if visual, I mean, I'm sure that there's a whole bunch of people out there ready to give them visual therapy. I don't know if it works beyond what they've been able to learn themselves by doing all that stuff with their head. I think theoretically it could, but I don't know of anything specific for them. That's a good question that I just don't know the answer to. So let's go to this. This is the next lady we saw with the dorsal midbrain syndrome who's got convergence retraction nystagmus. It's from Eric Enkenberger in Michigan.
Look at the pointer. Go ahead, real slow. Look at the pointer. Look at the 8.
So when she tries to look up, eyes converge and retract.
Look at the pointer. Look at the 8. Look at the pointer. Look at the 8.
It's hard to get to look up.
Keep looking right straight ahead.
Now, the best way to elicit convergence retraction nystagmus is to either have them look up with a saccade voluntarily or take an optokinetic tape and move it down.
Count them going down.
And as it goes down, you see the convergence retraction. To see the retraction, you may have to look lateral because it's retracting in the orbit, right? So this is not a nystagmus. These are converging and diverging saccades.
Going down. Look at each stripe.
Okay. So this was the case with the 1.5 syndrome. Here's the lesion on the left side of the pons that's giving you the gaze paresis and the MLF abnormality. Skew deviation is important to know about. It's very confusing for most people. It's quite simple. It's a vertical deviation. One eye's higher than the other. It's not a fourth. It's not thyroid. It's not myasthenia. That's all you got to know. One eye's higher than the other. It's not restrictive, and it's not due to a cranial nerve palsy. So it's due to the supranuclear input. It's from above. And it's a vertical disconjugate deviation. The pattern of deviation does not fit an individual muscle or nerve. It could be comitant, meaning the same in all directions, or incomitant. So it could be a right hyper in one direction and a left hyper in the other sometimes. That would be called an alternating skew. And it's due to a supranuclear defect of input to the muscles or nerves that move the eyes vertically, which is the third and fourth. So it's most often a brainstem lesion, but it could be cerebellar or occasionally peripheral vestibular even. So the most famous, for no reason, skew deviation is called the ocular tilt reaction. And this mimics a fourth nerve palsy. So it's a lesion in the midbrain or medulla, or actually even in the inner ear, in the vestibular system. And what it has is a hypotropia. One eye is low, and the head tilts towards the lower eye. So far it looks like a fourth on the other side. But both eyes are torted. They're rotated towards the lower eye. So with a fourth, let's say you have the left eye higher, the right eye lower. Your head tilts to this side because you see better that way. What's the torsion? It's the left eye, the eye with the superior oblique paresis is extorted or excyclotorted, right? But in this situation, with the ocular tilt reaction, both eyes are torted towards the lower eye. So that's the only distinguishing feature. So here's a patient with a right hyper. You might think it's a right fourth. It's actually that the left eye is lower. The head's tilted to the left. Again, it looks like a fourth. But we would expect that this right eye is excyclotorted if it's a fourth. And if we take pictures of this person's fundus, we see that both eyes are rotated towards the lower eye on the left. So here's the left eye with the fovea down here. Here's the right eye with the fovea up there. You see that they're both rotated. And sometimes there's an epidemic. Everybody's got it. So that's the ocular tilt reaction, a form of skew deviation. Peripheral vestibular disease we know about the acute labyrinthitis we're not talking about, but a peripheral vestibular disease where you involve both inner ears and you don't have any peripheral vestibular function is a sign most often of aminoglycoside toxicity like gentamicin. And it destroys the apparatus in both inner ears, and you get an absent vestibulo-ocular reflex. And you have oscillopsia, or shaking of the environment with any movement of the body. So people walk and everything shakes up and down. Even their heartbeat will make things shake up and down because you do get a body movement when your systole occurs. So here's an article in the New England Journal of Medicine of a surgeon who had gentamicin toxicity living without a balanced mechanism. And he talks about how devastating it is to his life, this peripheral vestibular disorder. This is about, I think, 30 or 40 years ago he wrote this. Now, we sometimes have a patient present with acute vertigo and nystagmus, and we have to distinguish, is it labyrinthitis or is it central nervous system? And we use this test called the head thrust test, which tests the vestibulocular reflex. And what you do is you rapidly move the head, and you look for a corrective saccade. And if you have a corrective saccade in one direction, that tells you that one of the inner ears is not working, and you have a peripheral process. So we'll show the head thrust test here.
And implies a vestibular loss on the
No
side
correction there.
towards which you are moving the head. This
There's a
leads
corrective
to
saccade at the
lateral
end.
loss on the right side. This
No
test
correction
has
there.
good specificity
See that
and
corrective
lower
saccade.
sensitivity.
So
Normal
with a good normal vestibulocular reflex, you should not have that corrective saccade at the end. That tells you that there's a
Watch
unilateral
again for
peripheral
the
vestibular
corrective
problem.
saccade after rightward.
This is more important for neurologists
Head movement.
seeing patients in the ER, trying to distinguish labyrinthitis from posterior circulation infarct. We're going to talk briefly about saccadic abnormalities. So they could be absent in oculomotor apraxia. They could be underactive, hypometric, or they could be dysmetric, just like a cerebellar lesion gives you dysmetria of your hand. You could have dysmetria of your saccadic eye movements. It could be slow. It could have an increased latency. It could be an inability to program multiple saccades in a row. Or it could be disinhibited, and you have things like flutter or opsoclonus. So here's a patient with dysmetria. When they look to the right, they overshoot and come back. Left is okay, right overshoots, comes back. Right cerebellar lesion. Okay? Just like finger to nose. Here's a patient with an increase in square wave jerks. Square wave jerks are these saccades away from center, wait a while, come back to center. And again, these are the patients, you're looking at their fundus and you say, or you're looking at their conjunctiva and you say, don't move. And then she says, I'm not moving. And you say, you are moving. And she says, I'm not moving. But she's moving involuntarily. She has these little jerks away from center and back. These are called square wave jerks. Inability to suppress these little saccades. So everyone normally has some of these, but people with neurologic diseases, it increases. Many different neurologic diseases does this. Let's say we can't suppress saccades at all, and they really go out of control. We have what we've seen last month, opsoclonus, like this young kid who's got saccades going in all directions and can't suppress them. And this is a young kid with a neuroblastoma who has opsoclonus. And you see that the lids move just like the eyes do. And then after the neuroblastoma is removed, you'll see that it gets better. And remember when they ask you, what image do you want on this patient in the ER or in admission, you want to get an imaging of the chest and abdomen. You don't want the brain, right? You want to look for the neuroblastoma. Pursuit abnormalities are numerous. There's poor initiation of pursuit. There's an asymmetry if there's a cortical lesion. There's low gain, which occurs in many diseases that are neurologic. It's very nonspecific. The most important thing we usually see with pursuit abnormalities is that when people try to pursue, they make these saccades instead because the pursuit breaks down. Classically, we see it in Parkinson's disease, but you could see it in a lot of neurologic diseases. So here's a person trying to make smooth eye movements, following a target, but you see these little jerks. So this is saccadic pursuit. In Parkinson's, sometimes in the neurologic literature, they'll call it cogwheel pursuit, just like the cogwheel rigidity. Convergence abnormalities, convergence or divergence insufficiency. We see that a whole lot in our clinics. Divergence insufficiency, a huge problem in older people who can't diverge, have a little esotropy at distance, not at near. We called it supranuclear forever, but now we know also from Joe Deemer in California that this is part of the sagging eye syndrome, which is a local phenomenon where the extraocular muscles insert into the globe, and so it may not all be supranuclear. We have convergence insufficiency frequently in any kind of neurologic disease, particularly Parkinson's, but again, we see it congenitally and we see it in older people as well. So I'll give you an unknown here. 50-year-old woman who has a history of an ascending aortic aneurysm discovered coincidentally on an ultrasound. She had an uncomplicated repair with aortic valve replacement and repair of the aneurysm, and she wakes up and she has difficulty looking around. She uses head movements to look around. She's also got complex partial seizures. On exam, normal afferent function, normal pupils, normal fundi, hyporeflexia, and a normal field. She has normal pursuit, but she can't make any saccades, either volitional or reflex. She has normal vestibular response and a normal VOR suppression. So she was published, and here's the video that goes along with it.
Now just try to look at the target.
So she's trying to look to the side with her head not fixed, and she does it by moving her head.
Camera. Right at the camera there. Look at the target.
After this, she'll have to make eye movements without moving her head.
Target, please.
She can't make saccades.
All the way out there. Good. And now look at the camera.
See, her saccades are extremely slow.
Look at the target up here.
Can't look up with saccades either.
Now quickly look back at the camera. Target out to the left here. Way out here. Now look at the camera.
Very slow
Look at the
saccade.
camera.
Smooth pursuit, really fine. Right? So can't make saccades, has normal smooth pursuit. Optokinetic.
So just try to look at the stripes as they go by.
So you'll see some slow eye movement, but no corrective saccades. So with the optokinetic, we expect to see she just moves over to the side. Her optokinetic slow phase is normal. She doesn't make any corrective saccades. This is a vestibulocular reflex, perfectly normal, right?
And let's do that up and down.
So, up and down, perfectly normal with vestibulocular reflex.
We're just going to do some more.
She can also make these movements. So if she gets videoed, video oculography, if we monitor her eye movements, no saccades at all. Here's the target, here's her. Pursuit, beautiful. There's the target, and there's her eye movement. So first of all, where's the lesion? What's the answer? Is it A, B, C, or D?
D.
What?
D.
D, of course. Where can you have a lesion that's going to give you all these things? I mean, there's no saccades anywhere, in any direction, and every other eye movement's normal. There's no one place there's a focal lesion. Is it supranuclear? Of course. Can't make saccades, but everything else is normal. So it's only one system involved, and that's the answer. All right. This is the only lesion we found on her right there, but that doesn't account for this. So this is a diffuse ischemia that occurred during her surgery that we don't know exactly how it works, but impairs saccades. And this paper that we published had 3 patients like this, and there are about probably 20 or 30 in the literature of patients undergoing either heart surgery or aortic surgery that wake up with an inability to make saccades due to ischemia that may be global somewhere, but it's very unusual. Nobody can really understand it. But it's a supranuclear. It's devastating. The patient that I had, which is not this one, I had one of the others here, was a journal editor, and he couldn't read afterwards. It's a devastating problem, even though you look at him otherwise and he's neurologically intact. One final case, 35-year-old man.
Did any of those patients resume function, or?
Mildly. Most of them did not get better. I mean, they learned to read by the same mechanism of their, moving their head that way, but when you do that at age 50, it's not as easy. So here's a 35-year-old man who I saw in '08 with sudden onset of diplopia. He had seen in the ER, CT, and then MRI. They found a lesion. He had a biopsy. He had a diagnosis before I met him. He was treated for it. He had diplopia that got better, and then he complained of blurred vision and couldn't really give detail. But he knew he covered his left eye to see. So I saw him neurophthalmologically. He was normal afferent function, except for congenital dyschromatopsia. His pupils were sluggish, 1+ reactive to light, but a much better reaction to near. He only had 60% normal up gaze, and he had an exodeviation in down gaze. Fundoscopic exam was normal. So here's his video. You ask him to look to the right, and he looks fine. Looks fine to the left. Down, he looks okay. Looking up, what happens? Look way up, what happens? So what do we see? Traction. Okay, where's his lesion? Answer is? Midbrain. Okay, sure. So actually his prior workup showed an enhancing thalamic lesion, and it was a glioblastoma. And he had gotten chemotherapy and radiation by the time I saw him, and this was his MRI with his large thalamic lesion pressing on the midbrain, giving him a classic Paranode syndrome or dorsal midbrain syndrome. So, supranuclear because you can overcome it with a Dahl's maneuver. Okay, so I thank you for your persistence with our video dysfunction. Glad to take any questions. It's all clear, right?